So the definition of high-risk Ph-positive ALL is really evolving, and it really is linked with the types of therapies that we use. So historically, with intensive chemotherapy plus TKIs, we saw that, for example, additional chromosomal abnormalities were associated with worse outcomes, as well as IKZF1 plus genotype. We saw as well with, for example, the chemotherapy-free regimens like dasatinib and blinatumomab, that IKZF1 plus genotype was also associated with poor outcomes. But we've seen more recently with blinatumomab and ponatinib that the only factor that we've found to be associated with worse outcomes was high white count at presentation. As well, we know that post-treatment outcomes, for example, MRD response is associated with risk of relapse. So patients that have poor MRD clearance or suboptimal MRD clearance are more likely to relapse. So it really is evolving with the types of therapies that we use. At MD Anderson, our primary approach is to use blinatumomab and ponatinib, and for this patients treated with this regimen, we really only consider patients with a high white count at presentation that's over 70,000 to be high risk. So how do we try to improve outcomes for these patients who actually could have a relapse rate as high as 50%? We've introduced 2 cycles of high-dose chemotherapy into the blinatumomab regimen. The goal is to, with high-dose methotrexate and cytarabine, that this could hopefully penetrate into the blood-brain barrier and help prevent CNS relapses. We also try to send these patients for CAR T-cell consolidation on a clinical trial. So the results are still early, but we're hoping that we'll see better outcomes with these strategies, and we're still trying to avoid transplant for these patients. So even high-risk Ph-positive ALL, our goal is to avoid transplant and try to cure them with just immunotherapy, perhaps some amount of chemotherapy, as well as CAR T-cells.